Nephrotic Syndrome Summary. Nephrotic syndrome, characterized by massive proteinuria, hypoalbuminemia, and edema, is a significant glomerular disease in pediatrics, often associated with minimal change disease (MCD) in children. Understanding the etiology, pathophysiology, diagnostic findings, and treatment modalities is crucial for specialist pediatric doctors managing this condition. Etiology: primary idiopathic, predominantly MCD in children, but also includes focal segmental glomerulosclerosis (FSGS) and membranous nephropathy. Secondary, less common in children, but includes diabetic nephropathy and lupus nephritis. Pathophysiology: glomerular damage leads to increased permeability to proteins, especially albumin, resulting in proteinuria. Hypoalbuminemia, due to protein loss, leading to edema and hyperlipidemia as compensatory mechanisms. Diagnostic criteria: massive proteinuria, 3.5 grams 24 hours in children adjusted for body surface area. Hypoalbuminemia, serum albumin 3 grams per deciliter. Edema, particularly periorbital, progressing to peripheral edema. Hyperlipidemia, elevated serum cholesterol and triglycerides. Urinalysis may show fatty casts indicative of lipiduria. Treatment overview: 1. Corticosteroids, first-line treatment for MCD and some cases of FSGS. Prednisone, standard initial therapy for MCD. 2. Immunosuppressants, used in steroid-resistant cases or specific glomerulopathies. Calcineurin inhibitors, cyclosporine or tacrolimus. Mycophenolate mofetil, alternative for patients with contraindications to calcineurin inhibitors. 3. Supportive care, ACE inhibitors, e.g. enalapril, or ARBs, e.g. losartan, to reduce proteinuria and manage hypertension. Diuretics, e.g. furosemide, for edema control. Statins, for hyperlipidemia management if needed, though less common in pediatrics. Complications and monitoring. Thromboembolism, increased risk due to hypercoagulable state. Consider prophylactic anticoagulation in high-risk patients. Infections, due to loss of immunoglobulins, maintain vigilance for signs of infection. Nutritional deficiencies, monitor and supplement as needed, particularly for vitamin D. High yield points for specialists. Selective proteinuria, predominantly albumin loss, is characteristic of MCD, differentiating it from other causes. Steroid responsiveness, a hallmark of MCD, guiding initial treatment choice. Biopsy, indicated in steroid-resistant cases to confirm the diagnosis and guide further therapy. Multidisciplinary approach, involvement of a pediatric nephrologist, dietitian, and possibly a hematologist for comprehensive management. This summary provides a structured approach to diagnosing, managing, and educating professional specialist doctors on nephrotic syndrome in pediatric populations, highlighting key pharmacological interventions and monitoring strategies. Clinical case: pediatric nephrotic syndrome. Patient information: age 6 years, sex, male, past medical history, generally healthy with no significant past medical or surgical history, up to date on immunizations. Presenting complaint: the patient presents to the pediatric clinic with a 3-day history of facial puffiness, noticed particularly around the eyes in the mornings, which seems to persist throughout the day. The mother also reports that his shoes have been fitting more snugly, suggesting peripheral edema. Clinical examination. Vitals: blood pressure within normal limits for age, other vitals stable. Physical exam: notable periorbital edema and mild pitting edema around the ankles. No rash, joint swelling, or other significant findings. The abdomen is soft, non-tender, with no hepatosplenomegaly. Investigations: urinalysis, 4+ proteinuria, no hematuria, no significant cellular casts. Blood tests: serum albumin, 2.1 grams per deciliter low, total cholesterol elevated, serum creatinine and electrolytes within normal limits for age. 24-hour urine protein, 4.2 grams per 24 hours, adjusted for body surface area. Renal ultrasound, normal kidney size with no structural abnormalities. Differential diagnosis: minimal change disease, most likely given age and presentation. Focal segmental glomerulosclerosis, less likely without a significant past medical history. Secondary causes: infection-related, medication-induced. Diagnosis: based on the clinical presentation and laboratory findings, a presumptive diagnosis of minimal change disease, MCD, the most common cause of nephrotic syndrome in children, is made. Management plan: 1. Corticosteroid therapy. Prednisone 60 milligrams per square inch a day, maximum 60 milligrams a day, as a single dose in the morning for 4 weeks, followed by tapering over the next 4 to 6 weeks based on response and side effects. 2. Supportive care. Sodium restriction to help manage edema. Fluid intake monitoring, balancing hydration needs, and edema control. 3. Monitoring. Weekly urine dipstick tests for proteinuria at home. Follow-up blood tests, albumin, cholesterol, renal function in 2 weeks, then as needed based on clinical response. Blood pressure monitoring due to the risk of steroid-induced hypertension. Discussion points. Importance of patient and caregiver education on nephrotic syndrome, potential side effects of steroid therapy, and the significance of adherence to the medication regimen and follow-up. Discussion on the prognosis of MCD, highlighting the high likelihood of response to steroids, but also the possibility of relapses. Instruction on when to seek immediate medical attention, such as signs of infection, significant increase in edema, or any new symptoms. Follow-up. The patient to return for evaluation in 2 weeks or sooner if symptoms worsen or new symptoms arise. Further evaluations and adjustments to the management plan will be based on the clinical course and laboratory findings. This case outlines the approach to a pediatric patient with suspected nephrotic syndrome, emphasizing the importance of a thorough clinical assessment, appropriate laboratory investigations, and a tailored management plan focusing on the most likely etiology, which in this age group is MCD. Nephrotic syndrome and minimal change disease MCD share some characteristics as MCD is a common cause of nephrotic syndrome, especially in children. However, there are important distinctions between the general condition of nephrotic syndrome and MCD as a specific underlying cause. Below is a comparative table highlighting these differences. Feature minimal change disease, MCD, a clinical syndrome, hypoalbuminemia, and definition. A clinical syndrome characterized by significant proteinuria, hypoalbuminemia, hyperlipidemia, and edema. A specific histological subtype of nephrotic syndrome, often idiopathic, characterized by minimal changes on light microscopy, but diffuse foot process effacement on electron microscopy. Causes can be primary, idiopathic, or secondary to conditions like diabetes, lupus, infections, and drugs. Primarily idiopathic, thought to be related to T-cell dysfunction. Rarely, it can be secondary to drugs or malignancies. Age predilection can occur at any age, but primary causes are more common in children and secondary causes in adults. Most common in children between 2 and 6 years old, but can occur at any age. Diagnosis based on clinical presentation, lab findings, proteinuria, hypoalbuminemia, and sometimes kidney biopsy to determine the underlying cause. Diagnosis is often made by kidney biopsy, especially in adults, showing minimal changes on light microscopy but diffuse foot process effacement on electron microscopy. Treatment. Treatment varies depending on the underlying cause, but often includes corticosteroids, especially for primary causes. First-line treatment is corticosteroids with a high rate of response. Relapses may require further courses of steroids or steroid-sparing agents. Prognosis, variable, depending on the underlying cause. Primary nephrotic syndrome in children has a good prognosis, but secondary causes related to systemic diseases may have a poorer prognosis. Generally excellent in children, with most responding to steroids and having a benign course. Adults may have a slightly less favorable prognosis and a higher relapse rate. High yield points. Nephrotic syndrome is a broad clinical presentation that can result from various underlying kidney diseases, including MCD, focal segmental glomerulosclerosis, FSGS, membranous nephropathy, and others. Minimal change disease, MCD, is one of the most common causes of nephrotic syndrome in children and has a characteristic lack of significant changes on light microscopy but marked changes on electron microscopy. The treatment and prognosis of nephrotic syndrome significantly depend on the underlying cause, with MCD generally having an excellent response to corticosteroids and a favorable outcome, especially in children.